Hola, muy buenas. Bienvenidos a este Cardio on Earth monográfico y específico sobre el papel de la mujer en la cardiología. Como sabéis, durante años llevamos recibiendo la visita del capítulo de Florida del American College de Cardiología. En los años previos hemos tratado distintos temas de interés para ambos, pero ha parecido interesante, propuesto por ellos y muy bien visto por nosotros, el tratar la situación distinta de la mujer en la cardiología en Estados Unidos y en España. A ellos siempre les ha llamado la atención que en la Sociedad Española de Cardiología hubiera muchas mujeres. Ya quisiéramos que hubiera más, pero son bastantes. En ellos la situación es algo distinta, aunque hay bastantes, como veréis. Entonces se hizo la propuesta de hablar sobre estos temas y para ello contamos con invitadas, tanto americanas como españolas, que van a plantear la situación tanto global como luego de formación de las mujeres. Y a partir de ahora voy a presentar a las ponentes y vamos a ir desarrollando el resto de la presentación en inglés. Okay, I would like to introduce, we know the Spaniards, but I'd like to introduce a Dr. Jennifer Corvu, who is going to speak first. She is Associate Professor of Pediatrics, Radiology, Obstetrics and Gynecology, and Director, Fetal Cardiac Program, and Director of the Single Ventricle Program of the College of Medicine. She just told me that Chair Elective of the ACC Women in Cardiology section, so is knows very well the situation of the women in cardiology. Belong to the Congenital Heart Center at University of Florida. We also have Michaela Lake, that is a non-invasive cardiologist, lifestyle medicine board certified, but Florida Lauderdale in Florida, Fort Lauderdale I think is the city, yes. Okay. From Spain we have Cristina Lozano, President of Young Cardiologist Group of the Spanish Society of Cardiology, National Ambassador of ERA in Young EP, and Leticia Fernández Friera, del Comité Científico Mujer y Corazón de la Sociedad, socia fundadora de Atria, Centro Integral de Enfermedades Cardiovasculares de HM Hospitales y de HM CIEC. We are going to talk about the situation and also about the pathway to get to be a doctor, a cardiologist in Spain and in the States, and trying to put in perspective also the work-life balance that I guess that is going to play a significant role. The first to talk is going to be Dr. Vu. Go ahead and explain what is the situation of women in cardiology in the States.
Good morning, and thank you so much for having us and inviting us to Madrid. This is to talk about how the status of women in cardiology is. And so let me introduce the American landscape. So first, we're going as mentioned, we will talk about experiences as women in clinical practice first, then we'll be talking about the training pathways and medical education next, and lastly, we will talk about balancing career development and personal life. So where are the women in cardiology? So in the US, about half of internal medicine and pediatric residents are women, compared with 21%, only 21% of adult cardiology fellows are women, but pediatric cardiology fellows, there are 50% who are women. There are 50.4 women in population in the US versus only 13% of women are in cardiology. And so the number of female doctors has grown from 28% in 2007 to over 37% in 2021, but still that number does not reflect the gender demographics of the overall population. Again, 50-50, and we're only 37% that are women. So in our section in Women in Cardiology in ACC, you can see this is a busy slide, but currently there's a more current number where there are over 1,200 members, but you could see that only of these cardiologists, they're broken down into different subspecialties. There is a paucity of cardiologists that are interventionalists. So there's only 12.3%, up to 12.3% that are interventional cardiologists, those who do cardiac caths. And for EP, there is around 6% only that are women. Most of the women are non-invasive cardiologists and heart failure and preventative and nuclear medicine. And we will talk about it more. Why is this? Why are the women gravitating towards the non-invasive imaging fields once they are in cardiology? Now, this is just a prediction of how the population or how the increase of women in cardiology will be in like 10 years, in 10 years from now, let's say 2017 to 2027 to 2037, 2047, and up, so on and so forth. And you could see there's an upward trend of women cardiologists, and there seems to be a downward trend of male cardiologists, but you can't see in like 40 years from now, the difference in number is still outstanding. We'll just rise up to 35% of women, and then the men will just be like, if they have a decline, they're still 60%. And there's no intersection. Now, in the Association of American Colleges, Medical Colleges, the AAMC data on promotion, you could also see that women are less likely to be promoted, especially as professors. So as assistant professors, there's 7% women assistant professors, and as it grows up, you could see that it goes from 11% total to like 5% and now to like 1 to 4% as professors, compared to males who are getting promoted up to like up to 12%. So why is this? And this is just one of the studies in 2017 published in Circulation of the sex differences in faculty rank among academic cardiologists in the United States. In this study, there's 3,800 cardiologists identified, and only 16.5% were women. And as we've mentioned earlier, the female cardiologists were less likely to be full professors. There's only 16% of full professors that are women versus 30.6% that are males. And they are also less likely to be associate professors, 24% women versus 22.6% that are men. And they're more likely to stay as assistant professors, where there's 60.2% women versus 46.8% men. And even after adjusting for factors known to affect academic rankings, women were still less likely to become full professors. And why is that? And this is just from the study of Dr. Silver, where this figure shows how women's careers in academic medicine are threatened by gender-related structural and institutional bias. And so the overlap of circles just demonstrate that the more entities involved in gender bias, the more a woman's career is harmed. So each level of threat, so where that lighter shade of pinkish is called the single threat, and as you overlap them, they become double threats and triple threats. And so each level of threat may be more profound for women with intersectional identities, meaning that they're not just women, but also women and minority. So the leaky pipeline in academic medicine is often attributed to individual choices to pursue other opportunities. However, a strong synergy of structural and institutional gender bias makes it very difficult for women in academic medicine to advance in their careers. And so this is just another illustration on how gender bias influences academic promotion. So you could see that those without a threat, it's easier for them to to advance to become full professor up to their retirement. But as the threats increase, and you could see the blue with the triple threat, the years it takes to get promoted to full professor gets nearer retirement for women. And let's talk about sexism in cardiology. This is just, as you know, there are a lot of studies that show that frequently when we are invited in conferences, there's a paucity of women getting invited in panels, that there's this coined word for it, that if the panel is full of men, they're called manels. And it happens all the time. And why is there no women in the panel? And it's because, and that's why we need to be more cognizant of the fact that women are frequently forgotten. And of course, because of these, all of these lack of promotion, or the time it takes for promotion to happen, salary inequity invariably follows. There's female physicians in academic medicine in the US earn 90 cents for every dollar made by their male counterparts, and there's an annual difference of up to $20,000. And then in Doximity, there's a Doximity survey of physician compensation report in 2024, and this is based on 33,000 physician compensation surveys completed in 2023, and these responses came from full-time physicians located in the United States, and there is a pay gap that remains significant. Women physicians in general, not just in cardiology, earning nearly $102,000 less than male physicians on average after controlling for specialty, location, and years of experience. And though there is a 3% decrease in gender pay gap, which could be a positive sign, it is important to consider in the context of overall compensation trends observed in 2023, notably that this reduction occurred at only half the rate of the 6% increase in average physician compensation during the same time period. So overall, survey respondents were also asked specifically if they think there is a difference on how male and female physicians are compensated, and 75% of women think that there's a disparity of pay. But if you ask males, only 30% of men agreed with that sentiment, so 70% think that we're paid equally. Again, this is an illustration of how the women physician, male physician pay gap goes through the years. In 2017 to 2023, you could see that there is that the gender pay gap remains consistent. And what does that mean in one's overall career? Salaries of women in cardiology are 7.3% less than male salaries over 35-year period, and the starting salary is an average $300,000 per year for men and only $279,000 per year for women in cardiology. But both men and women get a 2% raise per year. So if we think that, let's say we invest half of their annual income in stock market and other equity investment with a 5% annual return, because of that gender pay gap, there's a 2.5 million wage gap in cardiology in females versus males. That is for your overall career span. But why are women paid less? Do women physicians give worse care? In contrary, a large study published recently in the Annals of Internal Medicine examined data from 770,000 records of Medicare patients who were hospitalized between 2016 and 2019. And in this analysis, they both discovered that male and female patients were less likely to die and had lower readmission rates within 30 days after leaving the hospital if their care was led by a female doctor. Female patients specifically benefited significantly more from being seen by a female doctor than male patients did. So we know that women physicians give better care, yet we are paid less. And in 2018 study of over 580,000 cardiac patients admitted into Florida emergency rooms also found death rates for men and women were lower when they were seen by a female doctor, and women who were treated by male doctors fared the worse. That's shocking. Another study analyzing over 1 million surgical patients concluded that patients treated by female surgeons have lower likelihoods of adverse outcomes at 90 days and 1 year after surgery. And lastly, a review of decades worth of research has shown that female doctors tend to have longer conversations with patients, on average more than 2 more minutes, and 2 minutes sometimes matters, of FaceTime than male doctors. So how can we address this gender inequity in cardiology? So I think it needs intentionality. We need to have inclusion. We need to be diverse, especially in America. We need to have be intentional in making sure that we have women on the table, especially in leadership, that we have women mentors, and we have to be able to network to lessen this gender disparity. Because we need to have a culture change, social, societal, and ethical culture change, because this is a moral responsibility to treat half of the population, to make sure that they are addressed and their needs are addressed. And also, it's very important to have institutional commitment and professional commitment among the societies. And so what are actionable targets and policies? We need to have, we need to draft these changes and enforce, and we need to have every single institution and every single individual to be held accountable for these changes. So I think I'll stop there. And this is the situation and the landscape in the US.
Okay, now I would ask Dr. Lake to make any comment about this. Do you would like to add anything about that?
Absolutely. First, I want to say thank you for having us here and allowing us to shed light on a very important topic. And I think change starts here. It's conversations like these that lead to the change that we so badly need. I want to stack on something that Dr. Kovu mentioned very eloquently in that slide where she showed the number of female surgeons rising over the next couple of decades, but the number of female cardiologists not rising at the same level. And the question is, why is that? Their field is as demanding as ours. Despite the fact that they work just as hard, they still have far greater numbers. 25% of all surgeons in the United States are female surgeons. Well, what are they doing differently? The American Society of Surgery does a lot better job of pathways. They have a lot more mentorship. They're intentional about it. And that has paid dividends. And so as a result, younger surgeons now have a greater chance of having a senior female surgeon to mentor them. And that creates somewhat of a positive feedback loop. Many of us didn't have that. And so to have a seat at the table, we had to pull up our own chair.
Okay. I think it's, you expressed clearly the situation. There is, striking for me is the great attrition of doctors going to cardiology, no? Because it started at least 50% and turned out to be 55, no? Now we're going to pass to discuss the situation in Spain, no? So Leticia, Dr. Fernandez Friera is going to present the data in Spain before we move to the pathway of the career, no?
Okay, so thank you very much for this kind invitation. It's my pleasure to be here and share this type of conversation, which I think is critical to change people's mind. It's great to hear you and see that the problem is all over the place, because sometimes we have the feeling that it might happen only in our hospital, in our country, but that's not real world. So knowing your data is stimulating for us to say, okay, so there is a lot of room to improve. So thank you very much for sharing your data with us. So it's my pleasure to share the real situation of women in cardiology in Spain. So briefly, I want to give you an overview about what's going on based on data from the Spanish Society of Cardiology. If we take a look here of the distribution of cardiologists, both attending cardiologists and residents by age and gender in Spain, we can see that it's more frequently to find older men as attending cardiologists than older women. Then if we move to young men and young female, we see that the prevalence is quite the same. So it seems like we are getting better here and we are improving. And then from last decades, it was more likely to find a male cardiologist, while now it's more likely to find a female cardiologist if you take a look of younger people. If we move to residents, we see more or less equal prevalence between younger men and younger female in the situation. And then very nicely, if we take a look here about what's going on subspecialties of cardiology, if we take a deeper view of what's going on about male or female on clinical cardiology, on ischemic heart disease, on cath lab people, EP cardiologist, preventive cardiologist, imaging, heart failure or valvular heart disease, geriatrics, familiar cardiomyopathies, or pediatrics, we can obtain different messages here. If we go for invasive cardiologist,
doesn't work?
Yeah, it's working
okay.
now. Thank you. It took a while. So we can see here that as it's happening in your country, if we go to interventional cardiologists regarding cath lab or EP lab, it's more likely to find male cardiologists than female cardiologists. Also, which is quite of shocking, if we go to clinical cardiologists and prevention cardiologists, also we find more male than female. Regarding imaging, heart failure, heart disease, or geriatrics, we can see that there is a trend of finding more female cardiologists than male cardiologists. So it seems like imaging is more attractive for female than for male, as heart failure units and also valvular heart disease, which has a lot to be with imaging, and geriatrics. And then if we move to familiar cardiomyopathies and pediatrics, we see more female than male, as our mate just told us that pediatrics tends to be more picked by female cardiologists. This is based on data from the Spanish Society of Cardiology by scientific sections by sex. Bringing up some issues that I would like to discuss later about experience as women in clinical cardiologists, I think it's very important to see that sometimes we have other expectations. People think that we have to do more than male to demonstrate or to show same skills, and there are some cultural pressures in clinical roles. Also, it's important to take into account that authority is being questioned more frequently in male compared to male, and then sometimes we feel some explicit discrimination or hostile behavior in our clinical practice. It's very important that you also talk about it, the fact that we need more mentorship based on female women to follow, and some women-led networks. Similarly, we need more female role models, also in leadership for clinical practice and also for academic medicine. And what about the fact that we have to share our professional life with our personal life. No, some advices we can take here from is, for example, we have to struggle with all call duties, ongoing training, and family responsibilities. We tend to have persistent guilt and feel external pressure in both professional and personal roles. We don't have to feel guilty. If we work, it's fine. If we are mother, it's okay. Then sometimes institutional policies often lack support for real work-life balance, for example, flexible schedules or parental leave. And then we have to develop some personal strategies, for example, time management, boundary settings, or support from networks. It's very important, I think, and then I would like to know about your opinion, to prioritize our mental health and self-care as essential, not optional. And then the feeling is that younger generations are more vocal now, and they are starting to set boundaries and advocacy for flexibility work models. Thank you, and then I'm open for discussion later on after my partner, Cristina.
Thank you, Dr. Fernandez Friera. I think that we can keep all this to the end for discussion. No? Now we have clearly exposed the situation in both sides of the Atlantic. No? The problem is clear, even some possible solution has been singled out, and we can discuss about them later. And now we are going to talk about the training pathway, the training itinerary in both sides, because this can play also a role. No? Dr. Lozano Granero is going to explain to us the training pathway for a cardiologist in Spain that is about the same for men and for women, but sure you get some differences. Go ahead, Cristina.
So thank you for the invitation, first of all. Well, I would like to briefly expose which is sorry. Thank you. Our itinerary here in Spain, which is very different from the American way of training. Here we have a 6-year medical degree. This takes place at the university. There's an entrance exam which is quite difficult, and usually you have to have the best academic results previously on your training to get access to the medical degree. Here in Spain, females tend to get better academic results prior to university. So the situation is that in university there's 80% women versus 20% men nowadays. So well, it's quite feminized, the medical degree here in Spain. Well, there you get your usual medical training, a lot of theoretical knowledge. There is not quite there's room for improvement in training in practice skills here at the university level, which is something that could get better at the university. And after that, after the 6 years medical degree, you have to take an important exam, which is the MIR, the Resident Medical Internship. And here you get a position to ask for a residency program in any hospital in Spain. So again, cardiology is one of the most difficult specialty to get access to. Here in Spain, cardiology, the surgical specialties are less feminized than the medical ones, but cardiology, being a medical specialty, is the less feminized of them all. So here in Spain we also have this tendency to get a little bit more males than women, taking into account that 80% of medical degrees are women. So after that, you have the specialty training, which is a 5-year program. There's a first year where you have core training in internal medicine, general hospital rotations like emergency rooms, ICU, etc. And then you have 4 more years to get the focused training in cardiology, when you learn about cardiac imaging, heart failure, etc. And after that, you get your diploma as a cardiologist, and then you can opt to make a subspecialization in any other field in the cardiology. This is not yet officially regulated, but we are working on that from the Spanish Society of Cardiology. But usually it takes 1 or 2 more years of training, and as it is not officially regulated, well, the financial situation in this part of your training is not well established. Some people opt for grants or other ways to finance this training, and usually it can also take into account and stay abroad to learn about something specific on EP, on any other subspecialty. And after that, you can perform a national or a European certification to back that theoretical knowledge you have acquired during this training. So again, if we analyze the situation of the super specialties here in Spain, as you already said, the invasive ones are less feminized than the others. There is not a clear explanation of this. Maybe it has to do with the lack of role models of women in important which can do as a role model for younger people. And well, as there are less women are attracted. So it's a situation that's hard to overcome. But it also could do with other things like, well, that can explain that women tend to gravitate to more clinical or less invasive specialties. Usually they say about us that we do not like to take risks. Like while driving, we drive better than men because we take less risks. So in the invasive cardiology, you have to take risks, and that could be an explanation. And also the X-ray exposure, because we have this. We want to be mothers. There's the pregnancy, and well, this could be something that can draw back people from doing EP or cath lab. I don't know what if you think the same about this.
Now we are going to move on to the training itinerary in the States, and Dr. Wu is going to, and after that we can start.
Thank you. All right, unfortunately, I don't have slides that are similar in like, content like what you said, like you broke it down. But my colleague, Dr. Lake, will tell you more about like how we do things or how we do training in the US. Again, this was just a slide where we talked about earlier, where half of the internal medicine pediatric residents are, but this is just a more of all the residencies and all the subspecialties, and you could see here how many percent of females are there. These are trainees by sex, analyzed in one of the data gathered during 2015-2016. So there's 45% of all residents are female, and you could see by subspecialty there are more surgical female trainees than cardiology. If you could see that square there, that general cardiology, especially interventional and EP, have like the least number of females amongst all the subspecialties. And we also know that women physicians experience more depressive symptoms compared to men during their internship year. In the US, internship just means our first year of residency. That's what we call internship. And so how do we address this? We build support to increase representation, like you've said, in women in cardiology. And this is one of the studies that has been written by my colleagues in Women in Cardiology and ACC. And so how to do this? You have to recruit talent and cultivate interest. So you will need dedicated longitudinal cardiology mentorship and research programs organized by professional societies that needs to start at the medical student level. But I have to challenge that even it needs to start before the med school. By med school, we already have leaky pipelines. And as an example, I need to give a shout out. One of our medical students from University of Florida is here with me. One of my mentees has joined me to listen to us today. And she's hopefully wants to be a women cardiologist in the future. And then so we need women in cardiology need to be visible in leadership roles. You cannot be what you can't see, right? The more that women can see other women doing cardiology, the more that they think that it can be attainable, and not listen to other people, which are more frequently non-medical, that will tell them, oh, why do you want to be a cardiologist? It's so hard. You want to become a mom? That's not possible. You need to work both, and you cannot do it because cardiology is a difficult field. But we need to show these women that we can do it. We can be both parents and cardiologists at the same time. And we need to increase women in cardiology in teaching roles to be in direct contact with students at their preclinical and clerkship levels to show them that we can do this. And again, mentorship and sponsorship is also important that are coming from men. We need allies. We need he for she. These male, our male colleagues should be able to say, hey, I've seen my women cardiology colleagues can do it, you can do it too. And don't discourage the women from doing cardiology. And lastly, there should be workplace support during training. Like you've always, like here in Spain, I think you have better parental leave than us in the US. And so we need to address that, establish clear policies addressing gender-specific issues to ensure awareness and distribution of these policies to everyone. In our center, we have in our a lot of institutions that are happening right now, we're not just saying it's maternity leave, it's parental leave. And we encourage our male colleagues to take it as well, to normalize that this should be done and this is necessary. And again, we need to provide transparency during the application interview process. I think that so the bias in like recruiting males, because men won't take maternity leave, will be, or other reasons will be we need that to be transparent. And so to be able to have equity in and be able to have like more diversity in our field. So I'll pause here, and I think Dr. Lake can tell us more about training in the US. Like how is the trajectory and how do we start?
Sure. So one of the first things I noticed when you presented, and thank you for that, is the length of training. I think I counted 11 years to become a general cardiologist here in Spain. In the US, it's 14 years. And so that, I think, is a big barrier for women entering the field, because this all happens during the time of childbearing. So it's 4 years of a first degree, a bachelor's, and then 4 more years of medical school, and then a residency, which is 3 years, and then an additional 3 years of cardiovascular fellowship training. So that's already 14 years. Stack on top of that another 1 to 2 years if you desire to be a subspecialist. And I think that partially explains that widening of the gap, that disparity that we see at the subspecialty level, where only about 5% of our subspecialties, of our subspecialists are women. But again, drawing that comparison between our proceduralists in cardiology versus other proceduralists, they still have far greater numbers of women in their field. And the question is why? They work just as hard. And it's not, it tells me that it's not just the procedural nature of medicine that's a barrier of entry for women. There's something else. And I think part of that something else is the predictability of work. So even with general surgeons, having up to 25% of their surgeons being women, their subspecialties, breast surgery, thyroid and endocrine surgery, they have more predictable schedules, which are very important for women when they are trying to raise a family. And so I think we need to be aware of some of these and be more creative. I think institutions also need to be more creative about how we incorporate women and to make it more palatable with different types of work schedules, as you alluded to allow women to pursue their passions. I also think those pipelines that Dr. Kovu alluded to are very important. There's published data in the surgical world from 2017 where they looked at pipelines starting much earlier. And what they found is that students who were introduced to procedural fields at a very early stage and involved in those pipelines, up to 75% of them chose a procedural subspecialty after. So those pipelines are very important. In cardiology, our pipeline is starting in residency. That's far too late. By that time, so many people have already decided what it is that they want to pursue. So we need to capture people earlier, women earlier, medical school, even before that. And the surgeons have done a great job of that. They have pipelines starting in preschool. And I think it's made such a large difference. And I think that's part of what we can learn from here, is that we can funnel people into training with the right type of pipelines.
Yeah, I also think that it's very important, the families.
Yes.
Even the father, the mother, the brother, sometimes we forget that they even tend to provoke that the male will take engineer careers and the female will take another type of career. So I agree with you both that it's very important to provide a great education on medical school, because otherwise we go late. And then also to the families, and then we need to find females and males models to follow. For example, from other specialties, engineers, mathematics, physics, because at least in Spain, less than 30% of women dedicate to those careers, the STEM careers that we call here in Spain. So that's very important to empower women and make them believe that they can do it, trust their values, and see references, including surgeons from other specialties, maybe female surgeons, that will tell their experience or their life, the good and the bad part of their lives, not only the good, but then how they face the bad aspects of their trajectory. So I think those aspects are key.
Yeah.
I think that is right. And in this new generation as well, I see a lot of those TikToks and Instagram reels and a day in the life of, right? They do that and they love it. Like, oh, day in the life of a cardiologist. And I think if the trainees or even us are given the opportunity, that'll be nice to show them that this is a day in the life of a cardiologist and it can be done. We can show the good and the bad, right? We pick up our kids, they start with, usually the residencies, the residents are like, they start with brushing their teeth, and then up to the end and drinking a smoothie or something like that. And then for us, I think it's nice, it will be nice to show. I have 2 children that I've been picking them up or and then dropping them off while listening to a Zoom meeting and participating and multitasking. And I think showing them and even showing non-medical people that this can be done may get us those preschoolers. Hey, I saw this person in TikTok or in Instagram that she's a woman and she was able to do cardiology. I think you should be able to do cardiology as well, or be a surgeon, or be whatever, a doctor, and be an engineer. Because I think I agree with you. It's the layman who sometimes deter. I was being deterred when I was growing up. Oh, you want to be a cardiologist? It's going to be very hard. How can you do that? When they're not cardiologists themselves. But I didn't have female role models to see. Had I seen people women like you who are powerful, who've been doing this, I would have been inspired more and I would have chosen this career earlier.
Yeah, I think younger generations are more lucky now with this
Yes.
kind of, for example, of activities from the
What do you
Spanish
think-
Society of
Yeah.
Cardiology. And I think it's very important means of communication. For
Yes.
example, as you say, TV
Yes.
or books, change the
Yes.
picture from a male having a heart attack and then put a female surgeon. I don't know, means of communications, just the common things during your day, or maybe in supermarkets. I don't know, in your routine days, you get a lot of messages
Yes.
every day.
Agreed.
What do you think could be the role of a scientific society, the Spanish Society of Cardiology, to try to improve the situation that we can work doing this? What do you think, Christine, about that?
Well, you are already doing something, no?
At
And
least
you-
we have a round table here with only
Yes.
one man,
quite good, quite good.
This is a womanal, right?
Yeah. So we are having this discussion, for example, and I think the main thing that the Spanish society could do is try to get the women the visibility they deserve, like ensuring that the panels are more equal, or inviting them for, I don't know, maybe like Leticia, to the scientific committee of this association, this section, this, so we can have we can have our presence, our knowledge, our skills, and also, well, if there are women in the society, in the scientific section of something, they are gonna draw other women to get invited, get exposed, and I think that's the main thing that the society could do, like ensuring equality.
And also with the grants and the research area, which is so important. And then
Yeah.
you are giving the opportunity to ask for grants specifically for male topics. I think research, stimulating research activity in female is also very important.
Yeah, I agree. I think the societal level is where we will achieve change. That's how other societies have done that. The pipelines, the mentorship, but also there are other societies that reserve awards specifically for women who advance the surgical field, whatever field it is. Those are reserved to highlight the progress that women have made and the contributions that they've made. And those are other ways to highlight women in the field and to inspire the younger generation as well.
I'm quite interested about the preschool work that we can do. What they do at preschool.
Well, I
They
think just
show
introducing
children
them and
what is
just-
the word
yeah,
of that.
showing them.
Because could be a,
Right,
You
just
know,
a way
showing
to
them.
show. Yeah.
Yeah, I think to highlight something that Dr. Kovu said that struck me is you cannot be what you cannot see.
Sure,
My
no, that's-
daughter believes she can be a cardiologist because she sees me. But for someone else who's never seen a female cardiologist, that vision is not in their mind. So it's very important to have that image and to know that you can be that.
Okay, a quick question. You just showed that women usually earn a lower salary, but is for the same position? There is a different imposition, or this?
It's the same position, and we
how
have
they justify
equalized.
this?
Exactly.
Because
Well,
in Spain we don't have, at least in public medicine, we don't have this problem. You work the same, you earn the same money, but this.
and that's my question. Is it the same salary for, let's say, cardiology and pulmonology in Spain, they're the same? Or is it, like, let's say, your GI, pulmonology, cardiology, infectious disease, in the Spanish system, will it be the same salary
It's
for the
public
same rank?
system that is
Yes.
the most important, obviously.
I think in the US that's different. Cardiologists usually earn more than infectious disease and endocrinologists.
We see that because very often they publish this. We see how we earn much less here than there.
Right. And then there's lack of transparency in most institutions of how different cardiologists are making. And there are some institutions that will publish it so you can see, and then you can say, hey, why am I not being paid the same? But we've conducted surveys like this. Doximity has. We in American College of Cardiology recently conducted a salary compensation survey for pediatric cardiologists as well, because they think that we are being paid, male and females are being paid, but I saw that there's 20% pay gap based on self-reported salaries. And so these are all important, and I think it's a good societal, it's a good project for societies, and something that you need to advocate, because that's the only way that you, well, at least us in the US, will be able to say, to leverage, hey, this is real. I am not making it up, that I found out that we are being paid less. Is there a way? And for other people in leadership to see as well that, hey, maybe we should look at this. And again, it's not, why is that? We don't provide bad care. Women don't provide inferior care. In fact, there are studies that show that we provide better care. But why are we being paid less? Again, institutional bias, societal bias. We also get lesser opportunities. For example, and this is real, where chairs would not give us opportunities because, oh, I want you to, oh, there's an opening in this committee, being the leader, but I think you won't have time because you need to take care of your kids. Thinking with good intention that they are giving you time to take care of your kids, but unintentionally not giving you that opportunity to advance in your career. So the less time you can advance in your career, the less opportunity you can get more pay. In the US, let's say, and I'm in an academic institution, one of the determinants of pay is when you get promoted from assistant to associate, and from associate to professor, there is an incremental increase, a certain percentage of pay. The most advancement of like in terms of your pay increase would be when you get promoted from assistant to associate to full professor. And so if you don't get those opportunities, there will be harder ways to advance as an associate and advance as professor. Therefore, you will have less time to earn that much money, is also a problem, right? And so I think well-intentioned chairs, male chairs, protecting women from advancing in their careers because they need to take care of their family, I think is one bias that we need to change. And one time I was told that, and I said, but you have kids too.
It's true.
Why, like, can, and or, oh, I'm going to give this to your male colleague because he doesn't have to take care of his kids. Yes, he does. Yes, he does. You can ask him. I see him like bringing his kids to school too, like I do. And I think the more vocal we would be, the more that they suddenly understand. And I think it's a generation thing, right? And I agree that the younger generation are more vocal about their boundaries. And I think they will make change because it's a whole generation that is very cognizant and they're very vocal about their boundaries. And I think they'll make great change. Your generation will make great change.
Hope so,
Yeah.
Here in Spain, this salary gap, I think has to do more with other things than just the normal practice, because here in Spain, everyone is paid the same in cardiology, in surgery, etc., for your normal daily job. But aside from that, you have other opportunities to earn money doing other things like private practice. A lot of people in Spain have private practice in the afternoon to complement their salary in the mornings, or maybe, I don't know, in university, or well, with other things. And I think that female cardiologists are offered these opportunities less commonly than men, and that has to do with the salary gap here in Spain, or with the other things that come aside from your daily job.
Okay, I think we'll just going to the end. I would like to thank all of you for your clear presentations. I think that the problem has been clearly exposed. Many solutions. There are a lot of people that have to do things trying to change that, no? And we have a lot of work. As president of the Spanish Society of Cardiology, I also have my list of to-dos that is important. pasando ya al español, a despedir a las personas que nos oigan, quiero agradecer a los 4 ponentes las magníficas exposiciones. El problema, como he dicho, ha quedado claramente expuesto, que existe, que hay mucho que hacer, que es una cosa de futuro y que afecta a muchas partes de la sociedad, es un problema global. Obviamente las sociedades científicas también, y procuraremos hacer nuestro papel. Muchas gracias por vuestra presencia y espero que haya sido de vuestro interés y que sea de utilidad. Gracias.